we'll make sure that the recording is available on our website as soon as we can after the event. So I'll stop talking now and hand over to Zafar.
Thank you very much, Chris. And in terms of questions, people can post questions on the chat, and we'll pick them up. Yeah. Okay, that's great. Right. Okay. Well, I'm Zafar Iqbal. I'm an associate medical director at MPFT, which is Midlands Partnership NHS Foundation Trust, and I'm also an associate professor here at Staffordshire University too. So a very warm welcome from me as well in this second lecture series. We had some really fantastic debate last time round, and I'm sure today will be no different. I mean, we're looking into the future, so will the new public health and care systems improve pandemic preparedness? But naturally, you know, you can't help looking at how well we've kind of performed the various components of the public health system, whether it's PHE, local authorities, track and trace. And, you know, it's a really important question about how we prepare to deal with, never mind future pandemics, this particular pandemic we need to see through. And also, you know, the growing health inequalities and the really sharp drop in life expectancy we've experienced as well. So we're really fortunate to have two illustrious speakers with us. Roy is the country's leading independent health policy commentator on health and social care, and much sought after by media. He has held senior office in the NHS, local government, politics, and is a visiting fellow at the Imperial College Management School and the Centre of Health Services Management. Roy chaired the People's Inquiry into London's NHS, is the author of over 20 books on health and service management, and posts a free, thought-provoking letter 4 times a week on nhsmanagers.net, which I'm sure we can let you have details for. It's an absolute must for, and it's read by over 300,000 on 300,000 health professionals. And also a very warm welcome to Professor Sian Griffiths, who's a emeritus professor at the Chinese University of Hong Kong. Professor Griffiths worked and practiced as a service public health physician at local, regional, national levels before moving to her academic post in Hong Kong, a former regional director of public health. And she was also the president of the Faculty of Public Health of the Royal College of Physicians. And she chaired the Hong Kong government SARS inquiry, joining the University of Hong Kong as a director of the School of Public Health and Primary Care in 2005. In the UK, she's been an advisory member of the Board of Public Health England and chair of the Public Health Global Health Committee. She is currently a non-executive director of Public Health Wales and visiting professor at the Imperial College, and also deputy chair of the National Gambleware organisation charity. She was the original chair of Staffordshire University Centre for Health and Development, CHAD, which has organised this event. And so a very warm welcome to Sian as well. So we're going to start off with Roy, and then followed by Sian, but please do post your questions in the chat or comments, and we'll try and deal with as many of those as possible. So over to you, Roy.
Well, thank you very much, Mr. Chairman, and ladies and gentlemen, good morning. Oh, it's just afternoon. Sorry, good afternoon. That's a good start. Good afternoon. Thank you very much for inviting me to take part in this interesting discussion. It is a really pivotal discussion, really, about what is the future of public health. Before I sort of get into that part of the discussion, I wanted to set an historical context for where we started with all this. And when I say all this, fundamentally, I think I'm probably referring to COVID and the extent to which we were prepared for COVID and what we sort of did in the early stages. Now, for me, this is the starting point, and I'll explain why. Because whatever we've thrown, whichever baby we've thrown out with however much bathwater when Public Health England was dumped, whatever we replace it with, we have to test. I think the test is whether the new arrangements that we've got with the UK health and safety palaver, whatever it's called, would have done any better in dealing with what we just come through, I'm tempted to say, but what we are still going through, and who knows what is going to happen to us all in the next few months when we do finally realize, what son of COVID is going to do. So I think it's quite interesting, I think, to look back at the very start of our response to COVID in the public health context. Now, there had been a number of warnings that there would be some form of pandemic, something that we needed to prepare and get ready for. And it goes back, 10 years really, when the government were, I've got a really bad noise coming through. Someone's got a microphone. I've got a heterodyne whistle. Has somebody got the microphone? That's it. Thanks very much. Now there were specific warnings about the prospect of some kind of a pandemic in a 30-year window, going back as far as 2006. The Government Office for Science predicted that there would be a global pandemic within that 30-year window. So that was back in 2006. And they said that it would be due to a virus mutating from a wild animal or a human. So it was a zoonotonic transmission. Now, 10 years later, after that, in 2016, there were two exercises, and the full details of which were really dragged into the public domain by threats of legal process. They were called Cygnus, and there was a less known one called Alice. Now, the details of Cygnus were eventually dragged out of the health minister at the time, Lord Bethell, and he said that he didn't want it to be brought into the public domain because it might worry the public. But nevertheless, it did come into the public domain. And since that time, what a lot of people didn't know or don't know is that there have been 10 further exercises in the same year as Cygnus that were modeling different types of pandemics. Some were for Ebola, some were for the flu, but one was specifically for coronavirus and deriving its basis from the Sars outbreak caused by the virus. Now, this was kept secret. Now, the reason I know about this is that tomorrow, the People's Inquiry into Coronavirus is published, led by Michael Mansfield, and he details how this was kept secret, and we'll know much more about it tomorrow. So the government should and could have known. I mean, the narrative as it runs at the moment is, well, yes, we did Cygnus. It was based on a flu pandemic, not a novel virus, and we really couldn't have known any more. And we kind of did the best we could. We sort of muddled through. That isn't actually true. The impact of a kind of MERS outbreak was known, and as I say, it was rehearsed. Okay, so where was public health in all this? Where did PHE in London, where did they fit in? They took part in this, they were around the table, and no doubt they had a voice. We don't know what they said, and we don't know what those voices said, but we do know that they were there. Now, they weren't, it looks to me as though they were very effective. And you have to think, well, why? Well, I'll come back to that in a moment. Now, on the 10th of January in 2020, the World Health Organization issued technical guidance on how to detect, test and manage a SARS or MERS respiratory type outbreak. And on the 12th of January 2020, China shared the genetic sequence for SARS. And on the 23rd of January, Wuhan and other cities in China were locked down, and WHO declared a global emergency the following day on the 31st of January. And the first two cases on that day were confirmed in the United Kingdom. But it wasn't until the end of March that Johnson got off his backside and got his act together. And the government was caught, I think, seriously with its trousers down. And it's remained pretty much on the back foot ever since, trying to catch up. Now, there's been no accountability of that. And, you know, the rest of that, you know, is history. So my question is, where was Public Health England? It was certainly there. It was present at the table. What was his influence? Well, we do know that preceding all this, there's been about 10 years of austerity. The government reduced the percentage share on public services from about 45% of GDP down to 35%. It had a publicly declared policy of smaller government, and that meant collecting fewer taxes, and that meant spending fewer taxes. But of course, that was just disguising the fact that we were recovering from the world banking crisis, and all the public sector got completely slashed. Social services got slashed. NHS had a less than 1% uplift for 10 years, which is why now we've got one of the frailest times that the NHS has ever been with capacity and staffing. We don't need to talk about that today. We all know that. And it also left Public Health England emasculated. Public Health England's budget was reduced by a half, 40%. It was never designed to deal with a pandemic the size that it was facing back in 2000, back 2 years ago, and it didn't have the capacity. Its job was only to oversee the tests that were carried out in laboratories, were assayed properly. It wasn't its job to do it. It only had 2 public health laboratories, one in Portondown and one in Hendon, and it was only funded for 10,000 tests a year, those 10,000 tests being specifically around unusual and unexpected pathogens, a bit like Ebola or some other public health function around outbreaks of food poisoning and so on and so forth. So my question is, okay, so Public Health England was caught very short. It was under-resourced, it was unfunded, it was at the table, it had very little influence, and eventually Johnson sidelined it. Well, why? My contention would be that government realised that it had kept Public Health England on pretty small rations for too long. It was ineffective, and I think it was worried that it would be able to scale up. That was part of the difficulty as well, why it took central government so long to realise that the people who really could help during the epidemic were the public health community in local government, nearer to where the problems were. They didn't trust them to be able to scale up. So that's when we got the UK Agency for Health Safety, which is, you know, otherwise known as the New Public Health. And now it's had a huge budget. I mean, it's a budget the size of a small country, and it's still focused and preoccupied on a response to a pandemic. I don't see anything that Jenny Harris is doing now, which is connecting with health inequalities, is looking at data and how we can improve the lives, and to use the popular political phrase of the moment, level up. The connectivity with local public health, as far as I can determine it, is still pretty tenuous. Local public health have certainly come to the rescue of track and trace, doing the hard yards with the difficult cases. Test and trace, of course, is a whole other issue, which was set up in a panic and pretty much ignored the public health capacity and skills that we've had during the time of the pandemic. So we've had a kind of a cycle of panic, neglect, panic, neglect. Now, if you want to look at this in terms of a business case, the business case is overwhelming that a greater investment in public health, leaving aside the safety function, is long overdue, because we will continue to battle with fixing up a pretty unhealthy nation until we can properly get to grips with public health. And we have to look again at the history of public health. What has public health actually done about childhood obesity? Frankly, not a lot. What has public health done about diet and sugary drinks? Actually, it didn't do a lot. It was the law that changed sugary drinks. For example, the levy that there is now, the sugar tax, as it's called, the sugar levy, that has certainly encouraged the reduction of the consumption of these drinks with high saturations of sugar. And it leads me to thinking around public health. If you think about public health, public health is about the changing of public behavior. That's part of its job, leaving aside COVID and all the other stuff it does. It's about changing public behavior. If you look at what has really changed public behavior for the better over the years, it's been one thing and one thing only. It's been the law. It's the law that changes public behavior. Seatbelts in cars, crash helmets on motorbikes, health and safety legislation in the workplace. It is the law that has changed people's behavior, the sugar levy, the sugar tax, as it's called. So the extent to which public health can be successful in that context might be only the extent to which government is prepared to reach into the lives of ordinary people like you and me and stop us doing things. Has public health been successful in doing that? I would argue no. Is it because public health has been stupid? No. Is it because public health has been under-resourced? Yes. So I don't think we've seen the golden era of public health. I mean, if we go back to John Snow and people around the water pump, maybe. But in modern times, public health has pretty much gone off in a direction following different kinds of diets, different kinds of ways of living life, and the sofa. So where has public health been in all that? Well, I don't think it comes out of that with much credit. I think public health does come out with huge credit in the way that it's worked its magic in dealing with COVID and the COVID response, which leads me on to the second part of what I said I wanted to say. Do I think that the new arrangements that we've made around public health, because it's not actually in public health, around public health, will make the difference we all want? What is the difference we want? Well, what is public health? Public health is a safe place to live. Public health is a job, a decent job, a proper job, and the right to live a life and love whom you please. Those are the three pillars of public health. We've never really seen it in the past. And are we likely to see those three pillars fulfilled, being the foundation of the new UK agency? I don't think so. It seems to me the focus is entirely on pandemic response, which is fair enough, but is it likely that this new organisation is going to be able to say to the government, we want you to spend £100 million on PPE and put it in a warehouse somewhere in case we need it next? No, the Treasury won't do it. The government won't do it. Is it possible for the new public health organisation to say to government, we need to pass a law to say that certain elements of PPE should be manufactured in here and change the supply chain? Yes, that will be possible. Will they do it? I can't see it. I cannot see. I mean, Jenny Harris has not published her business case yet, or her strategy properly, and we don't really know what this organisation is going to do. This looks to me like it's a break the glass organisation. There's a new COVID thing or a new pandemic or whatever, break the glass, and they will do something. Public health is so much more. Public health is the foundation of a healthy nation, and public health should have a say in the health that we deliver, how it's delivered, where it's delivered, and who delivers it. This new organisation, for me, I can't see it doing that. It's too big. It's effectively, we need two organisations. I think we need a Department of Pandemic and Emergency Response, which is one part of the public health bag, and the other part of the public health bag is more about a decent job, a safe place to live, and a life to live freely. No, it seems to me that the new organisation is not prepared for that. The new organisation is designed around a whole new image, a whole new approach to public health, which is not properly defined. And when you think about it, public health is very basic. It's very simple. It's very easy to describe. What have we got to do to make the nation healthier, wealthier, and safer? Those are the three things that any public health organisation should be able to do. The one in the past didn't do that. It didn't do that because it had been emasculated, government wasn't prepared to listen, and in times of austerity, it was easy to cut their budget because most of what they did was below the waterline and the public didn't notice. The new organisation, will that be able to do it as well? For me, no. There'll still be a scramble for capacity if there is a new pandemic, and we still won't see the new arrangements reaching into the lives of ordinary people. The new arrangements around the redesign of the NHS are important. At last, we've scraped the lunacy of Andrew Lansley off our boots, and we're getting back to some structures that are meaningful. And with the local authority and health working side by side, that should make a difference. But if you look at the organisational structures, the extent to which local government will have a real say, I'm not so sure. This is not just going to end up cost shifting. There's a new white paper that's being designed about the relationship between health and social care, which is a very important part of the public's health. And it seems to me there are only two things that really are important. One is the ability to share money, because at the moment there's a Section 75 complication we needn't go into, but we need to make it easier for health and social care to pool resources. And secondly, we need to be able to share access to data. All those are the only two things that we really need to do, but there's going to be a hugely complex white paper. So in summary then, thank you for listening to me. I'm saying that the three things that I think public health should be able to do: a decent job, a safe place to live, and the life to live freely and happily, a healthy life. Public Health England never did that because it was emasculated and wasn't able to do it. The response to COVID has been woeful and we're still recovering. And the new organisation, I think, is too complex, too big, and too focused on COVID and pandemic response. And we've forgotten the valuable work that colleagues in public health do in local government. Mr. Chairman, I'll stop there.
Thank you very much, Roy. As to be expected, that was a very wide-ranging discussion there, very incisive, really thought-provoking, and it's very clear. And I love that phrase, I forgot the kind of three things, but I love that. That's a kind of, we use the sort of social determinants of health to describe public health, and that is a really good sort of layman's terms to describe what public health is. And it clearly has failed in if you look at in terms of health inequalities. They've been a massive drop in life expectancy, and the health inequalities have been increasing as well. So on many different measures, we've got a lot to improve on, and certainly a very interesting reflection on what the future should look like in terms of public health. Right, I think before we kind of take questions and answers, I'm delighted to pass on to Sian, and because I think you've been quite closely involved in the public health systems on a personal level at many different levels, either through the faculty or through Public Health England. So it'd be really great to have an insider's view on this. Over to you.
Thank you very much. And Roy, as ever, lovely to share a platform. It's some years since we last shared a platform, yes. But very nice to see you again. And so thank you for that. And as ever, I agree with a huge amount of what you said. And I think a lot of what I'm going to say will sort of support that. I'll say it in slightly different words, and I'll say it from the point of view of a public health professional. I noticed my title was View from the Public Health Community. I don't speak for the public health community. Obviously, I don't. I'm retired. I'm a granny, and I'm living in Oxfordshire, and I'm looking on, having spent many years in the Far East. And I was going to share with you all a few thoughts from that, and what we learned in Hong Kong and China, and then back to where we are now in the UK. But just let me say that from my point of view, it's even worse, Roy, than just having the UK HSA, which none of us can remember what it is. And by the way, that name only came out with the press release. And so Public Health England didn't know it was going to go to be the UK Health Services Agency. Neither did it know a few months later that it was going, the other bit, the residual bit, the health improvement bit, was going to go to be the Office of Improvement and Disparities, OHID. So Public Health England was split into three. There was another bit of it that then went to the NHS. Now, in theory, that is taking a part of the three domains of public health, which for years in the faculty we've been talking about: health improvement, health protection, engagement with health services. The three of them together provide the basis of public health. And within what we do, we talk about evidence, providing evidence, and I would fully support that we work through law. But I think you might say, Roy, that we do influence the law. We did influence the law as a public health community on the fizzy drinks, and we certainly influenced the law on smoking. And we've certainly taken a position through the research that Public Health England undertook on e-cigarettes, which have led to us using them as a smoking, as an aid to smoking cessation. But we can come back to all of that after I've made my remarks, because I think it's an interesting debate about how we can be more effective as a public health community, because I think none of us would say that we necessarily have been as effective as we could have been. So if I could go on to the next slide, please. Needless to say, my technology doesn't, because I'm on a Mac, I can't make this work. So, hey guys, I'm going to have to rely on my friends at CHAD. And I should say, I really enjoyed my years as chair of the I think the inaugural and only chair of CHAD, actually. As we set up, we were working between local government and the university sector. It was fantastic to be doing that. And I'm very pleased to see CHAD is running its inequalities seminars, because how we address inequalities was always a key part of what CHAD's mission was. But let's just go back to 2003, even earlier than Roy's 2006, because when we look at 2003, we had the Sars inquiry, and it was seen as something over there. And I would postulate that it's because it was seen as something over there, we never really learnt the lessons in Europe. And that's possibly why we are where we are now. But the Hong Kong government SARS inquiry looked very quickly at the epidemic. It turned out to be an epidemic, not a pandemic, although at the beginning no one was clear. And we came up in a paper in JAMA with Cyril Chandler and I as the co-chairs, with a very short set of what we learned and what we needed to see addressed in the future if we were to protect against another pandemic. Because as Roy said, we knew there would be another one. We knew that there would be another jump between animal and man. And we've seen several of those since this time, but we knew that coronavirus was going to sort of hang around and be there. And if you remember, the Sars outbreak was thought to have been from bats to civet cats, which are a delicacy, a wild animal delicacy, often bought in markets where the conditions are very unhygienic. I don't know if anyone's visited them, very unhygienic. And civet cats and civet cat to man. And that's thought to be the origin. It was the origin, which is something echoing now as we look at the origin of COVID-19. But the key messages were that infectious diseases remain a serious global threat. Therefore, they need investment, and that governments underinvest in public health. So just echoing what Roy was saying, governments underinvest in public health because public health is by definition precautionary. It is about looking for avoiding risk, and that requires investment. We also were very clear that if you have an outbreak, apart from needing to move very quickly, you need to have a lot of clarity about what it is you're doing, and you need to have a program. You need collaboration at all levels. You need very good communication. You need coordination at government level, at local level, and at global level. And you need capacity. You need to invest in your public health system. And what we saw after SARS, we saw huge investment across China in their CDC, and in Hong Kong, the creation of the Centre for Health Protection, and across the rest of Southeast Asia that have been involved in SARS. Huge investment in public health, and a recognition that public health was key to avoiding a problem in the future. You also need, when you have a pandemic or an epidemic, an integrated healthcare system, and that is geared to working together in crisis. And you have to be able to switch that on immediately. And you need the global system, the WHO. Now, we said all this back in 2003, and I'm going to finish at the end of my remarks by looking at where I suggest we've got to. If I could have the next slide, please. I just want to share with you what happened in Hong Kong. This is the picture of the pandemic. This is cases in Hong Kong. Here we go. Look, 0 to 50 on this axis, bobbling along here. Sometimes no cases, sometimes 1 or 2. Every case that's recognized is immediately contact traced, and that's how they picked up the case of Omicron, which had come in from South Africa for a person who'd actually gone into quarantine. Because if I could have the next slide, please. Thank you. The initial strategies this time round, having learnt from the SARS inquiry, having looked at what needed to be done, having invested in preparation for another pandemic or epidemic, they immediately moved to their zero COVID plan. Now, we possibly couldn't have done zero COVID. We possibly don't believe we should have done zero COVID. It doesn't matter. It was the plan. And the plan therefore meant border controls and travel restrictions with strict quarantine, still in place now, as we hear frequently in the news. A variety of social distancing measures were brought in. Mask wearing, of course, was an immediate one, and mask wearing has been very prevalent in Asia. Actually, since SARS, if you have upper respiratory tract infection, you usually wear a mask to stop you spreading it to other people as you go out into crowded places. Part of the way of life. And the other thing in Hong Kong, as in South Korea, was a very active test and trace, able to map very quickly where the cases were, whether they were passing on, and then able to take those measures around local lockdown, which we're all familiar with. Now, this was the initial strategies as reported back in April in the Canadian Medical Journal by my colleagues in Hong Kong. Perhaps I could have the next slide, please. Now, the reason that I show you Hong Kong is not that I'm saying we should have been like Hong Kong this time round, But what it was it demonstrates that Hong Kong had learnt from the SARS epidemic in 2003. It was ready. It was actually ready for MERS. It was ready for H1N1, and they reacted very quickly. You could say they're a smaller community, but they're also a high-risk community because of the population density. They're just an example. You can see the same example in Wuhan, in China, when as soon as they had made us all aware of the fact that there was a pandemic, there was action. I think actually there was not a lot of subterfuge in China. There may well have been cases in advance, but as soon as it became apparent that there was an epidemic in Wuhan, acted very quickly. So where are we? What happened to us in the UK? Roy has very eloquently taken us through my slides. I just would point out we haven't had the formal inquiry yet. I think it was very helpful for us in Hong Kong to do the inquiry very quickly, to be able to not blame, but to say, what can we learn and what do we then need to do to avoid a situation in the past? Of course, COVID in the UK has led to the brilliant research and science of vaccines and treatments. And I do think we have to be on the positive side when we look at COVID in the UK, as well as the fact that the public did respond positively in terms of community support, vaccine uptake, compliance with restrictions. Compared to other countries, we have responded well. The public is engaged. But I think we would all agree that we were slow to act in the UK. We didn't have a clear plan. We didn't act quickly. We had inadequate testing capacity, inadequate PPE, and failed coordination between the NHS and care homes. Now, you can pick me up on any of that if you want to in the questions, but I don't think we didn't start out very well, unlike places that had learnt the lessons. And you could say we could have learnt the lessons through the exercises that had taken place. If I could have the next slide, please. But I wanted really to focus a little bit more on the public health lens and COVID-19. And as Roy has already picked up, there was an initial lack of engagement with local public health teams. I think that was a fundamental mistake and symptomatic of the fact that since the Lansley reforms, it was told, and the public health system had been weakened to such an extent that the central arm, particularly of government, didn't think of engaging local public health teams early enough and using their skills, their ability to network in their communities, the ability to outreach. Once they started to engage, you saw brilliant examples of leadership by directors of public health and their teams, and you continue to see those. Local response and well-funded local response is an essential part of what we need to be able to do in the future. I want to just spend a few minutes on the disbandment of Public Health England mid-pandemic. It came as a shock. It was announced in the papers Sunday night in the Telegraph, and I think there was general disbelief that this was real. This was a political move. It was nothing to do with how well PHE were actually doing. As Roy has already pointed out, PHE was emasculated over the years leading up to the pandemic by continual underfunding cuts. It was also very unclear when PHE was an agency. It wasn't a free organization, it was an agency of government. And being an agency of government, it was a bit difficult to tell whether it was inside or outside. So PHE defined itself as an organization that didn't have the capacity to respond because of all the different players, the Department of Health, the local teams, etc., not all being part of a very well-coordinated system. PHE was providing evidence and also science, and obviously had Porton Down was very important in terms of the science and the development of tests and vaccines, but it was inadequate. The system was inadequate for the contact tracing that was needed. So PHE was in a difficult position, coming off the back foot, only able to do a certain amount, and people within PHE should be commended for the huge amount of work they did do, the way that links were created locally, and the way that they did get the system to work once we were facing the pandemic. I'm not sure that disbanding it in the middle of the pandemic would be in anybody's textbook of what one might do in the middle of a pandemic. However, I'll just leave it at that. I might say also that PHE, when it was reviewed by IANFI, the International Association of Public Health Institutes, an organization set up post-SARS to bring public health institutes together to share learning. That IAMPHI had recently visited PHE and said it was a model for other countries to follow, and other countries have actually followed a lot of the things, such as the emphasis on investment, the focus on health improvement, on inequalities, health protection, engagement with the health service. They were actually following some of the things that have subsequently been taken apart. But enough of that, I can talk about that more later. So if we look at the public health lens, we're there with local public health teams now recognized as an essential part of how to go forward. We have PHE in 2 or 3 bits, but we have the ICSs. Now, in England, and I don't know whether many of you may be involved and can join in the discussion and tell me whether or not this is going to help public health or not. I do know that public health in local authorities has been seen as a great strength, and I do think that we inevitably we need to keep that local engagement, the local systems. But how do you then integrate with the healthcare system? Because public health is not just about pandemic response; it is about how do we promote health through a variety of ways to make jobs and housing. As Roy has said, but also through how do we run our health services? How do we get them to focus on prevention, not just on treatment? System changes. Are we engaged in those system changes? I also think that the public health lens, the pandemic very clearly laid bare the structural inequalities of our society and the need to do something about them. And the question of whether the systems in the future are going to be able to do that is one which I would be concerned about if you only relied on the UK health I can never get it right, the Health Security Agency. If you only relied on UXA, the answer would have to be no. But how do you bring the public health community together? Can you do it through some of the structures that are there, or do we need to think again to bring the system together, to get the system to work to the advantage of the population's health? And I think it's not a bad time. My public health lens would tell me that the public and media are now very engaged in public health issues. Can we not use that as an opportunity? So my last slide, please. Oh, my second from last slide. I think the prerequisites to answering my question lie around these 5 I's. The need for investment. We've touched on that already. You need to invest in public health if you're going to have an adequate public health system. The public health system in the Far East was able to respond because post-SARS there had been huge investment. Are we going to see that here in the UK? You need involvement, and you need involvement at national, local, global level, and you need engagement. And we need to get full involvement in developing the future systems. The infrastructure, I would argue, needs to be reshaped, and we need to think about how that would work best for the future. And we must take the inequalities lens and make that an important lens for any future system. We've probably known a lot of this, but isn't it time now that we could actually push forward on this in the public health community to make it clearer? Because clearer to people like Roy, who has a definition of public health, which is absolutely fair. The UXA, that it's UXA, it's because we're not talking about some of the other things at the moment. We mustn't let them fall behind. And let's look at my last slide is just to ask you the questions of the lessons that we learned in the past. And what are we going to do in the future? And I was going to just hope that you could throw some light on whether you think the creation of UXA, OHID, how has that impacted on the health system, and how do you get it to be better? Do we have adequate funding? I mean, I know the answers. I might answer some of this, but how secure are the local public health teams? How is the funding? What about the sector grant? What about are our systems adequate at other levels? Global, national, local. What more do we need to do to create better systems to respond to pandemics in the future? Will ICSs offer the answer? And importantly, how can the World Health Organization be supported to be more effective? So those are just a few of my questions for the future. Thank you. We can probably take the slides off now. And I hope that they give you some food for thought and that you can respond to some of those. you know, because really we do face a huge amount of challenges as we look forward, because I wouldn't be confident if we suddenly got another virus that took off, which we could have. I wouldn't be confident that we could respond. And we need to think about, as a public health community, our responsibility about how do we respond and how do we make sure that we engage our communities, our local communities, our politicians in that response. So those are some of my challenges. I sometimes wish I was much younger, Roy, don't you? Don't you wish you were out there to be able to get on with some of this? It's very frustrating as you get older. You go sort of like, you know, I really would love to help, but you know, I hope I'm helping a bit by sharing some of my thoughts today. Thanks very much, Zafar.
That's very, I agree, Sian. I agree.
Wind back the clock, Roy.
If only.
If only.
That's actually really fantastic thinking, fantastic insight, and really sobering, Sian, to look at how Hong Kong responded versus how we responded and how prepared they were to get some of those measures into place compared with us. And I think you're absolutely right in terms of the sort of funding, and local authorities were decimated in terms of their funding. You know, I mean, it wasn't just the caps in their budgets, that the central budgets, also, you know, local authorities, because of austerity, there was additional cuts made within local authorities as well. So, and it really is fantastic credit to the public health workforce, the frontline workforce, who despite, both in local authorities and PHE, despite all the odds, you know, they actually came through. So it's really well worth recognising that. And I think the danger signs are there, really. We need to be able to, you know, not just meet future pandemics, but also deal with the structural problems that we've got with public health here in the future. So I just wondered, Chris, looking to you, I don't know what we've got in terms of questions and answers. I mean, before we got lots of, I mean, I don't know whether, Roy, you want to say something in response to what Sian has said before we go into the questions?
Yes, I mean, Sian put it very elegantly and much better than I can. And it was a great delight to hear her speak. I haven't heard her speak for a while because our paths haven't crossed, but I'm going to find my way up to Oxford for some more common sense from you. Look, I think we've got to somehow persuade government that public health is worth doing. And that's this difficulty, because there is almost no public health quick fix. I mean, there are some, but generally speaking, it's a longitudinal thing, and it runs beyond the length of a parliament to get the desired outcome. And of course, governments don't really want to invest in anything longer than about 5 years, because they need to show there's a payoff. So I think we need to come at public health slightly differently. Now, there's a way of managing change, and it's a two-layered way of doing it. I should have a slide. I'm going to try and describe a slide. But fundamentally, if you want to change something, there's two things you've got to do. I mean, first of all, the trick is in change is to make people think they're in charge. So make people think they're part of change. That's the first communication thing. But just park that. There's two things you do. One, you have a whole load of high profile, low cost, quick fixes. So you say to people, I'm going to change things, and you come in bang, 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 high profile, quick fix, generally low cost, quick fixes. And then in the background, you work at the longer range things, because if you say to people, I'm going to change the health of the nation, you'll say, yeah, it's going to, how long is that going to take? But if you suddenly do some high profile, low cost, quick fixes on the way, people say, you know what? It looks like this guy really means what he's saying. We are starting to see things change, because the way you change things is to show people that they start to see things change. Now, the big problem with public health is we have to find a way of doing these high profile, quick fixes that where people can see things change. And then in the longer run, in the background, leveling up. I mean, leveling up is the public health agenda. we've got a prime minister who wants to do levelling up because he thinks there's votes in it. That's fine. I mean, I can't stand Boris Johnson. He looks like he slept on his mate's sofa. I can't bear the look of him. But nevertheless, if he wants to throw money at levelling up, I'll have some of that, because levelling up is about the public's health. You can't level up unless people have got a job, a safe place to live, and they got the freedom to live and love the way they want. So that is levelling up. I'm all for levelling up. And that's, we should buy into that. We should be taking the money. We should be doing locally the quick fixes, high profile, low cost things, while the structural things about education, life's chances, a sure start, all of that takes place in the background. I mean, one of the first things, if you're going to ask me what I do, the first thing I do is to get the Sure Start thing back again. Now we've sort of got Sure Start Light, and that's okay. You know, fine, call it what you like. Can't call it Sure Start because that was Tony Blair's idea, and we can't do anything that Tony Blair said anymore. So we've got Sure Start. So we call it something else. And I'd get the Sure Start centres going again. And where would I send to them? I'd send to them around the food banks. I put them where the people are, put them where the people go, in the high street, bang, in your face, low profile, quick fixes whilst we do the longer structural in the background. That seems to me the basis of a public health policy. Sian will now say that was a load of rubbish and she's got 6 better ideas. But anyway, that's for discussion, Sian.
I think you're on mute, Sian. Sian, you're on mute.
Yeah, no, sorry. Yes, no, actually, Sure Start was building on the Healthy Living Centres idea, which was with the New Opportunities Fund, which many years ago I used to work with. And I really think investment in community-based support for young mothers or mothers with children, and to get the children the education. We know investment in education is probably the biggest thing we can do for health. And we really, you know, I think that that's a really good idea, and that's definitely somewhere. And I agree with what we've got at the moment is Sure Start Light. And we really need to be looking at where these centres should be and putting support in there, instead of which I hear people are squeezed even tighter. And the fact, Roy, that we would have to build it around food banks must be an indictment on us as a society. And I think we need to think about how we can get the, you know, especially at a time I'm just thinking, you know, food prices going up, fuel prices going up, increased pressure on low-income families, isolation post-pandemic, the mental health issues post-pandemic. We really need to see this action on this pretty quickly. And I don't know whether people working at local authority level think that we would be able to push in this direction, but maybe make it a priority and push in this direction and make a noise about it and engage people like Roy in promoting it. Because I do think, Roy, you are an influencer. You know, and you know, you know, I know you usually think of Stacey Dooley or someone as an influencer, but I think you're an influencer in the health service. And we need people like you supporting public health, because so often public health, until our improved PR from the pandemic, has always been something to do later on, something lower down the agenda, whether it's in the health service or in the local government. So push up the profile of public health and have some very tangible wins, such as ensuring safe start for under fives, for children, preschool children in particular, and making sure they're well fed and cared for. And I do think that's a really important public health objective. So I don't know if people think we can sort of get some energy behind it. The faculty, I think, Zafar, you're involved in the faculty. I think, you know, we need to be pushing at the local level at this sort of thing. And I know lots of people are doing individual things, but it needs to be brought together as a systematic approach.
Yeah, sorry, Mr. Chairman. Sorry.
No, that's okay. Carry on.
Well, I mean, I absolutely agree. And at the other end of the scale, it's about older people, isn't it, as well? You know, how do we keep older people out of hospital? It's easy. You stop making them need to go to hospital, you know. And so the hospital, 1 in 5 beds at the moment in the hospital have got people who are over 70, and they're taking up 75% of the available bed space because they got nowhere to go. And so if we look at the other end of the scale, if the average length of stay for an older person in hospital it's about, I don't know, it's about £300 a night, so that's £3,000. And then on top of that, you've got fairly lightweight medication because it's usually a UTI and a fall. So it's, I mean, so let's say 10 days costs about £3,500. Well, you could have stopped that by having a £12–15 visit from a healthcare assistant popping in to see people who are known to be frail, because GPs have been paid to do a frailty index. You just say the local GP, give me your frailty index, and you go around, you knock on the door, you say, how you doing, love? You know, do you need anything? Do you shopping? You give them the once over, look at for trip hazards, talk to them. Are they lonely? What's their response? Do they look as though they're slightly, you know, not quite all with it? And you know, an army of those people, you can buy a lot of those visits for £3,500. And so, you know, for me, that's public health. That's not health. That's public health, and that's what local government should be doing. And I'm not saying they you know, you say local government should be doing it. It sounds like accusatorial. I don't mean that. I'm saying that's, you know, something that they might like to do, and I'm sure they would. But the important thing then is, well, will the ICSs and the new white paper create the opportunity for health and care to share funding? Because I mean, and I'm going to do a bit of basic Janet and John here for people. It's a big audience today. I'm not quite sure who everybody is. Forgive me if you know this, but there may be some people that don't. When government votes money to the health service, it can only be spent on health. When government spend money on social care, it can only be spent on social care. Now, we brought those two together in the Better Care Fund, and we adjusted some of the legislation so we could blur the boundaries. Now, the Better Care Fund didn't quite work because people didn't kind of get it. They were mistrustful of each other, and there wasn't enough money. But the new white paper, my spies tell me, don't repeat this anywhere, I'm relying on the confidence of thousands here, but I'm told that there will be a facility for health and social care to pool resources without breaking the law. That's really important, because if you do that, if I was running a hospital still, and thank God I am still not running a hospital still, but if I was, I'd gladly give a few quid to local government to recruit an army of people to knock on doors and say, how you doing, love? Are you all right? Give us your frailty index. Let's go and see. Because I would stop people coming in. Now that's called vertical integration of health and care. And I think if we can do that kind of stuff, then we're getting into the golden age of public health. As it is, I think we're in about sort of aluminium.
Thank you very much for that, Roy. I mean, that's
we need some alchemy.
Yeah, yes, exactly. Very good point, Sean. Yes.
No, you're absolutely spot on about the amount of money we spend in the last kind of few years of life. And if you, I mean, I'm as someone who's critically been looking at this, Roy, over the last 6 months, a year or so, you know, and in a way that the quality of life is actually pretty poor as well. And actually, we're actually failing, despite all the money that is spent by the health service, we're actually failing older people in terms of improving their quality of life, improving their loneliness, improving some of the things that really matter to them. And instead, what we do is we give them lots and lots of tablets and keep them in hospital for deconditioning and all sorts. So I think the whole kind of system is not working for older people as well. Never mind the kind of disinvestment we have. I mean, it's criminal, really. The you know, sure stuff.
Brian Dolan talks about the wonderful Brian Dolan. Yeah,
Sorry?
he talks about the wonderful Brian Dolan talks about pajama paralysis, where people go in hospital, put their pajamas on, and that's it. They're finished. You know, it's simple, isn't it? You know, older people, they're warm in one room. They're immobile. They don't go for a pee, so they would realise that if, you know, they don't go for a pee if they don't drink, so they don't drink as much as they should, and they get a UTI, and they go in hospital, they get deconditions, they come out, and it's blah blah blah, and we spend a fortune, and it's madness. It is completely bloody bonkers that we know what we're doing is wrong, and here we are, intelligent, bright people, trained up to the eyeballs with more degrees and research, blah blah, than, you know, it would sink a battleship. Stuff, the knowledge that we've got, but we don't do it.
We don't do it, yeah. And it's a good litmus test for the new system, whether they can get to grips with this.
Well, is Jenny Harris recruit an army of people to knock on the door with a frailty index and say, how you doing, love?
I didn't mean yes. I mentioned England. The ICS.
That's when you go back to the real problem. It's AXA, and it's then within the Department of Health, and it's a bit in the NHS, and it's a fragmented system as opposed to a public health system that is together and focusing on inequalities. So unless they've come together, there's no way you're going to actually get.
And if I may just do something which is not in my job spec for this morning, but I've just noticed here that Victoria Riley, Victoria, hi, give you a wave, pleased you're here. She said, how do we encourage everyone, i.e. government, public health and the public, to prioritise prevention? It feels a lot of the problems have stem from a focus on treatment, not prevention. I mean, she's just kind of summed up what we're talking about here. Well, it's easy. I just think you show people that keeping healthy is a good thing. You know, how's your granny today? Ask people, you know, if you know you've got a frail granny, ask how she is. If you're worried, let us know. Okay, I know you live in Stafford and your granny's in Southampton, but ring her up for us. And if you've got a problem, give us a call and we'll sort her out. So, you know, I don't think we have to persuade people that not going to hospital is not a great thing. I think we engage people. We have an army of people. I mean, I know modern life. I mean, when my gran died, my dad moved the piano out the front room and put the bed up in the front room, and my granny died in the front room. Well, you can't do that now because, you know, we've all got through living rooms, darling, and you've got the kids playing, you know, on the telly at one end and your granny dying at the other. You know, we don't live like that anymore, but we've got a phone and we've got FaceTime and we have ways, and it's no good talking to your granny, because if you say you're all right, love, she'll say, yeah, I'm all right, leave me alone. But if you say, if you're worried about your granny, give us a ring, then we can do something. And it's, you know, just think about it. It's a 15 quid visit versus $3.5 grand in hospital. What do you want to do?
Right, I'd love to talk to you about this outside of it, to be honest, because there's so many opportunities for, for improving the care of older people, and the amount of money we spend is just shocking, absolutely shocking. As you said,
well, you know, 70% of hospital beds. I am older people. So
me too.
Yeah, well, I'm not going to ask Sian how old she is, because she is ever youthful, but I am 76, right? And it annoys the hell out of me where young people who can still cut their toenails want to tell me how to design services for the elderly. You shouldn't design services for the elderly if you can still cut your toenails. That's the key determinant. It's a bit like you shouldn't be a GP unless you've had a baby and gout. You're not qualified.
Yeah, I just wonder whether we could just have a look at some of the questions. So I think Hisham Haq has made some really powerful points about the lack of, about the fragmentation of the public health system. And he also makes a really, I think he works as a GP, he works, and he makes a point about how valuable social prescribers can be in terms of in terms of their role within primary care. And that's a really
is that Hisham Haq? Am I reading the right one?
Hisham Haq. He's got two posts, I think. He had a
right. I think he makes an important point. A government can kill off an entire organisation to scapegoat it. Yeah. Well, I mean, I don't think they wanted Public Health England to survive the pandemic, because let's face it, they knew where the bodies were buried. They knew exactly why it was in a mess, and getting rid of it, pretending it wasn't efficient. There was an uprising. I don't know. I mean, Sian, you must have seen this as well. I stopped reading my inbox. It just melted, you know, with people who told me really what was going on. And the lovely guy that ran it, I mean, it was a bloody disaster all round. But I think Hisham is right. I mean, there was a fair amount of Machiavelli involved in that decision, I think.
Yeah. Absolutely. Agree with you, and I think that the senior civil servants will admit that you should have a plan before you disband a major organisation, particularly if it's managing your pandemic. So I think there's sort of general agreement, and it'll be interesting to see the inquiry. I don't know what tomorrow's. I don't know if it's in the People's Inquiry. Roy,
yes, it is. I'm sworn to secrecy. I'm bursting to tell you, but
I know I'm bursting to read it now.
Yeah, it's a cup of builders and a hobnob read. It really is.
Very good, very good. Because I mean, you know, you shouldn't treat people like that, and then you're expecting them to, you know, they've already been working really hard through the pandemic, and they have to carry on working hard.
Yeah.
And you know, you don't know if you've got a job, you don't know where your job will be, you don't know, you know, all of that uncertainty. So as I said earlier, I think full credit to all PHE employees who carried on working through such difficult circumstances, and I think that, as you say, they know where the boroughs are.
And before that, Sian, I'd be very interesting to see what our audience say about this, because we've forgotten that before that, of course, public health was ripped out of effectively the NHS by Lansley's bonkersness and shoved up the back passage of the town hall. And, you know, did anybody want to do that? What was the impact on careers? Are they happy there? What happened? What happened to the budgets? What happened to the career structure? I understand now they don't get the same pay rises as local government, and because they're not in the health service, they don't get the pay rises the health service get. I mean, the whole community of public health has been treated very, very badly. The trouble is, very hard to get people to talk about it because they feel like, you know, they're going to get the sack or get their knuckles rapped. But if anybody's bold enough to tell me, I'd be really interested to see what they think. So I mean, they had a pretty bad start, didn't they? They were working pretty much where, you know, they suddenly arrived at a place they didn't know where the loos were, and then all of a sudden they got a pandemic to deal with, and then they were told they were going to be reorganized. Well, thanks very much.
Yeah, absolutely. Got a question. I might have a conversation with you privately outside, Rob, about that. And so what does the panel feel about the government's preparedness for an escape variant and their plans for resilience in the future? I suppose we're kind of covering that a little bit. I mean, are we better, do you think, Sian, to deal with the escape variant?
I heard Clive Dix talking on the radio yesterday, and I think there's a slight misinterpretation about how he thinks people are responding to Omicron at the moment. I think he put forward a plan and he put it into the, I don't know whether it was the department or AXA, but and he's never had any response to his proposals. And he also didn't think that cancelling the contract with Valneva was a good idea, because he thinks we should have our own capacity to respond. So I can't talk in great detail about his actual concerns, but his concerns is for, do we have the long-term, I mean, if I can paraphrase what I think I know, is do we have the long-term capacity to deal with an escape variant, even if Omicron it will be dealable with, you know, because it may well be that Omicron is transmissible, but not such a serious disease, etc. But we just don't know yet. So what he's talking about here is escape variants or other variants. Have we got the capacity to do our own preparation to create vaccines, etc.? I don't know if Nick wants to add anything else. I think that the response for Omicron is actually good. I think it's good to be precautionary. But I do think we just need to work as a global community on this and try to minimize the harm that's caused inevitably by taking certain measures.
There's a very good article in Byline Times this morning, and you can get it Byline Times, all one word, bylinetimes.com, and it's called Boris Johnson is making the biggest mistake you can make on Omicron. And it's by Adam Benkiev. It's worth a read. I mean, look, let's kind of move the fulcrum point for a moment. We have to keep the economy moving. You know, there's no argument to that. And I do understand the government's dilemma in, you know, keeping the coffee shops open and keeping the businesses running. I absolutely get that. But we've learned the lesson, haven't we, that whatever it is you're going to do it early, because if you do it late, you might just well not have done it, and you've got to do something worse. I was on the telly about 3 weeks ago now, and I got a shed load of abuse on social media because I said I thought a 2-week break at the end of November would have been a good idea, because you could kind of see the whole thing was boiling up again. And if I said wear masks, use your COVID pass to go anywhere and work from home for a fortnight. That should give us the break that we need to make sure we have a free run through Christmas. Of course, I didn't know the omnivore was going to depend upon us and devour my idea. It seems even more now that we should be saying, look, go with me on this. I know you're all going to hate me, but we're going to have a real crunch for, I mean, what have we got now? We're in the 1st of December, aren't we, tomorrow? So we've got about 3 weeks run up to Christmas.
3 weeks,
I mean,
just over 3 weeks.
Even if we did a 10-day, maybe a 7-day, really tight, go with me on this. Let's save Christmas. We can do this if we do it together. Boom. Galvanize public opinion, sort the front page of the Daily Mail out. I think we might come through this a bit better. But as it is at the moment, assuming this new virus knows the difference between a school corridor and a school classroom, I don't think it's that intelligent.
Yeah, I think things like mask wearing, I do not understand the reticence for mask wearing, why that hasn't been actually mandated for much longer. And I spent the summer in France with the vaccine passport. And really, it's not a big deal once you get used to it. It's just about getting used to it. Yeah. All you're showing is the fact you've been vaccinated. You're not showing a Q code. You're not showing anything else. And so I really don't understand what the reticence to act quickly, because we're running at a very high rate of Delta at the moment, very high rate. And what that doesn't tell you, even if you've got low hospital rates, you've got a lot of morbidity in the community. It's not a pleasant disease to have. And people talk about it as if it's sort of like, oh, it's so, you're not hospitalized, it's okay. That's not true.
But the question then is, okay, where's the public health leadership? Where is the independent voice of public health saying this is what we should be doing? You won't get it from Jenny. I mean, she's a lovely lady, and I'm not being rude about her, but she's been put in that job by number 10. Yeah, it's obvious. She is totally conflicted in her. Public health should be entirely extant. Entirely, an arm's length isn't long enough. It should be outside government.
And that's what actually PHE, as an agency of government, the control from the department was such that they were able to act independently. So even if they had wanted to in the early stages of the pandemic to make other statements, because they're part of the machine, the government machine, unable to do so, even if they had evidence to the contrary. Yeah. And so there's a sort of sense in which you need an independent voice. So in a way, you need the profession, I think. Well, it has to be the professionals to come together.
Yes, you're right. I mean, SAGE is supposed to be independent. They meet in secret. I found out the way they calculated the R number. It's a lottery. It's a whole load of opinions they put in a hat and pull out the one they think is most likely. I mean, the R numbers are bonkers calculation in my view. I defer to all public health big brains, but it doesn't.
I think they stopped using R numbers very much recently
because it's bonkers.
They are very difficult.
So SAGE isn't doing what it should be. Independent SAGE is terrific, and you can watch their meetings. They're on YouTube. Google Independent SAGE. Terrific people there. I mean, all right, they're all fully paid up members of not the Conservative Party, but nevertheless, they're professionals and they tell it like it is. If we're going to do anything with public health, it has to be much more than an arm's length organisation. It ought to be able to speak entirely independent government and publish everything that it thinks and says, and then it's up to Parliament to hold the executive to account, or the government to account, to say, why are you not following public health guidance or public health recommendations? And they may have a very good reason. It may be that it's good advice, but hey, we don't want to do it because we got something else we need to achieve. That's fine. But what we don't have is independent voice. And the problem from that is we've never really had real public health leadership. There was never, a single person or a single organization or a focus of public health that stood up and said, okay, we're public health. This is what you should do. This is what we think. And here are the reasons.
No, that's absolute gold dust, Roy. I mean, you do need that independence. And if you go back in history, you had independent directors of public health locally as well. We haven't got that at the moment. You know, the local authority directors of public health don't have that same degree of independence that we used to have. They used to produce, these are the local problems, without fear or favour, and this is what we need to do about it. And I think that's kind of gone. That's really worth gold dust.
It is, and it's worth asking yourself the question: if Jon Snow had said that the infection is coming off the water pump, would Boris Johnson have demolished the water pump?
When would he have demolished it, Roy?
What? So
when would he have demolished it?
What are people saying about us? Is anybody going to give us a sack? Have we got any questions? We've only got a few minutes left, haven't we? Time banks. Let's talk about time banks. Time bank is a great idea. Have you come across that, Sian? This is where people, I go out and cut somebody's grass, and then somebody comes in and teaches my kids how to do algebra. I love it. It's a really good idea. We have social prescribers in one day, and she can look at 6 patients and call them, social prescribing. Well, I mean, that's Sir Sam Etherington.
Yes, absolutely. Yeah.
If you've never met Sir Sam, look up Sir Sam Etherington. It's Ever. Yes. He runs a GP practice in the East End of London. If you go and see his GP practice, you've got a garden centre and a coffee shop, and somewhere in there's a GP working. It's fantastic.
Yeah, and that's actually an old idea from the Peckham project back in the 1930s. It's a project, it goes almost back to the old utopian societies. You guys in Stoke, you know about those. There's a sort of sense in which it is about communities coming together and trading off within communities. And I think, but the concept of social prescribing is very good as well. That's one I would support. That is public health. That's, go to the gym. Here's a prescription for the gym, not here's a prescription for pills. Here's a prescription for exercise. The approach to healthy living, and a very positive approach. So I think that, maybe supporting more social prescribing. I think the College of Health does that, doesn't it? Mike Dixon's group are very into social prescribing. My local GP is into social prescribing, and I think it's a really good movement. So perhaps we could seed that around a bit more and fund it.
I'm trying to get my GP to give me a season ticket for the Arsenal, but he won't play.
Well, we have to contribute. I think that's part payment, Roy.
I absolutely. Have you seen Men in Sheds? Have you come across Men in Sheds? I'll tell you about Men in Sheds. It's a charity, Men in Sheds. You can Google it, look it up. And what the charity does, it puts a shed in, puts all the tools and bits and pieces in. And old geezers like me go to the shed, and you make a few bits and pieces for your grandchildren, or and some of them make fantastic stuff. And of course, all these old geezers are in the shed, and we're all having a cup of tea and having a moan about the government, and we watch a bit of telly at lunchtime, and then some of them have got a bit of an allotment now on them. Oh, the Men in Sheds is fantastic.
That's a great plug for a.
That would be good in Stoke. I know from my time as chair when we used to walk. In fact, there are some schemes a bit like that in Stoke.
They took a lot of flack because it was men in sheds and not women in sheds. But I understand the ladies are there doing stuff as well. Please don't write to me.
Making the tea, Roy.
Don't write to me. No, don't write to me. I didn't invent the idea.
I think Roy and Sian and whoever's in power needs to look at the report tomorrow. We'll also look at the video recording of this session here today. We've got some fantastic ideas, and we'll probably put the World Public Health world to rights.
Sian has trashed her elegant career by association with me.
But this is just awesome stuff. Awesome stuff. I'm so glad we've got this recorded, because the exchanges between Roy and Sian brilliant. You made a point, Roy.
Hang on, somebody's got their microphone open.
Till when is she here?
Could you all check your microphones, please? That's it. Thank you.
You made a comment which resonated with me when you said how do we persuade the government to invest in public health? We've just been through a catastrophic pandemic. We've seen the importance of public health, and if we have to ask ourselves that question now, how can we persuade the government to read public health? We're in a dark place still.
Yes, I absolutely agree with that. I mean, if the government can't see the business case for investing in the public's health, then we're wasting our time. I mean, in fairness, they're throwing billions into getting the NHS up and running. There's a recovery plan which was supposed to have been launched this week, but hasn't. That's been put off because of the recent events with the pandemic and so on. So it may be out this week, it may not be. But I mean, it has a shed load of money attached to it, and of course if that doesn't tell you, I mean, all of that money invested in what was certain, of course, people want a new hip or a new whatever and getting the NHS back on its feet, but what a tragic waste it's been, because we came into COVID with the lowest bed numbers in Europe, the lowest number of nurses per head, the lowest number of doctors per head, the lowest scanning and investigation kit per head. I mean, the NHS was on its knees before we started. So before we can even think about doing 6 million people have got a waiting list problem, we've got to sort out the problem so it can do it. It's absolutely an overwhelming case. But what is against it is it's the electoral cycle and the inability of governments to act cross-party in the best interests of the nation. They act in the best interests of their electoral prospects. Fair enough. That's our politics, but that's the reason. Silence.
You're on mute, Zafar.
You're muted.
Sorry, I'm just saying that's a really sobering thought, Roy. I've really enjoyed this conversation. Thank you so much, Roy, and thank you so much, Sean. And I'll pass over to yourself, Chris, to kind of wind this up. I think we're just about to run over time now, aren't we?
Yeah, thanks, Zafar, and thank you very much to Sean and Roy. That was brilliant, really fascinating insights and very wide-ranging and some really good stuff. So and thanks also to Zafar for the chairing and to Patrick for helping to organise this. I'll just
can I have a disclaimer? I'm still working at the moment, so no. Okay, yeah. So the final thing before we close, just want to remind people of the series of events we're going to have in the first half of 2022. So each of our monthly webinars looking at a different issue or inequality exposed by COVID. So we'll make sure that everybody who registered for this is invited to each of those as they come through. But so yeah, I'll close there and just say thank you much to all those who have contributed, and have a good day.
Thank you.
See
Bye-bye.
you all.